to a more mid-range position and I ask them to resist, if it's actually the musculotendinous unit, I would expect it to be painful in all of those ranges, right?
Yeah.
If I'm only getting pain, say in this position, resist me there, but I bring him to here and I ask him to resist me and I don't get it, the difference might be I'm only catching a chondral lesion underneath the patella in one of those ranges of the knee versus having an actual musculotendinous strain or overuse.
And that brings up a good question. There's always a question. So in this position, what facet are we on? How many ridges does your back of your patella have? 3. And so this is the odd facet. This is the one that you'll find they talk laterally. This is the one that, you know, because of the extreme position of the knee, it doesn't usually, it's usually a lack of compression. So odd facet, middle ridge, lowest. Okay, so that's a good point. So you'll find that depending on where you are in the range and test, it may give you an idea of where on the patella it's giving you trouble. Okay, how many people do a lot of work with patellar mobility? Okay, but there, yeah, post-surgically I do a ton with the mobilization, but again, where would you expect this patella based on the reinforcement if you're in neutral? Which glide should be most restricted? He's a good example of that because you reinforce so much more laterally than you are medially. And so I don't do a ton with patellar mobility, although in standing again, when it's tracking off, you have a pretty good idea that you're stretching those structures. Okay. Okay, so range of motion. So let's talk a little bit about mobilization. And this was the one that Gail really wanted me to show. I see a whole bunch of knees occasionally when they have a restriction in range. And what, in my opinion, they get restricted is it's the rotational moment. All right, and that's what doesn't come along. So if I was to think about, let's talk about this, let's just say for instance, oh yeah, ligamentous stress test, I'm sorry, I knew you were going to say that. So ligamentous stress test before we go on. If we're talking about the medial is, I said 15 centimeters, right? What's that right there? Oh, pays centimeters. Centimeters. This is my Canadian coming back. 15 centimeters long, or how long is that? 5 inches? 5 inches? Okay. That goes to my wife's favorite joke. Do you know my women?
I'll turn this off.
Oh, my wife's favorite joke is why are women such poor carpenters? Because they've been told that's 10 inches their whole life. Okay. So if it's this long, we have 3 components. In extension, when we do this, okay, we've locked everything up. They say we're testing the most. What part of this ligament do you think you test the most of? Posterior. Now, do you believe in extension that your MCL is your only resistance to that valgus? What else is there? Let's go from inside to outside, or outside to inside. MCL, capsule, meniscus, ACL, PCL. So when you have that O'Donoghue's unhappy triad they always talk about, right? You've got a whole lot more damage going on than your MCL. How many isolated MCL strains do you ever see, Cindy?
Couple.
Yeah, most of them, I mean, isolate is pretty tough to do. 30 degrees, what are we testing? More of the middle, okay? And at 90 degrees, okay, what are we testing more of? Anterior. Lateral, they say 0, right? And then 30, and that's always a little tougher. Why do they say after 30 it's just a waste of time? Yeah, IT band comes off a stretch. Okay, Lockman's, okay? Lockman's test. I suck at the Lockman's test. And if Don Bost was here, he is a pro. But basically at Lockman's at 30 degrees in neutral, yeah, not bad. What you're trying to do is they say that's where, and it makes sense, 30 degrees out, lateral compartments unlocked. And what you're looking for is not so much, I used to get fooled thinking it was this big anterior translation. What you're looking for is infield. And so it should feel like it tightens up, okay? Why do we get so many, I mean, sometimes you get a false negative, so it's torn, because of what?
Swelling, muscle activation.
Pardon me?
Guarding.
Muscle,
Muscle
guarding, swelling, okay, so you can get that. The one that I like the best for PCL, we used to do this. The one that I think for PCL is absolutely the best is this, and they call it the gravity test. So that when it comes down, gravity takes it and it's a sag. And sometimes you can think that's ACL because it comes from back to the front, but again, it's just infield. But that's the sag that you see with the PCL.
We had a fresh PCL last weekend, isolated piece, well, and a little bit of posterior lateral corner. But his best test, well, he had a positive SAD, but it was the quality of his lockments, because it looked like he had lockments, but when you looked at where that restraint came in, he was right at neutral.
Right.
He didn't come any past. And so he had a really, really good learning experience for our students to
So
show them.
what's the history, if we clustered this up, what is a PCL generally? How do you tear your PCL? And I saw a bunch of them, not recently, but I saw a bunch.
A
Car-
lacrosse player, push from behind.
Yeah, or the big one was hockey player before they had the flyaway posts. That's why they got flyaway posts, because they come in, they get tripped, and they hit the tibia right on the front of the post that's not moving, and they just tear their PCL. We saw a lot of them when I was
We
younger.
usually have one PCL a year in lacrosse because of the push from behind them, they land right on their tibial crest.
And then
it
just go right for it.
Yeah,
Shears them
straight
forward.
line falling on ice.
Yeah.
Just
I got a few soccer players.
Yeah,
Right.
sure, yeah, PCL going forward, run into it. I'm trying to think, I've seen the most bizarre things, Cowboys, we've had those run into them, you know, stuff like that.
They heard everything.
Yeah, yeah. Okay, so ligamentous stress test, so, okay, so, one of the things that, and I always say it, it made me with the orthopods here was post-surgically, when people have a scope, where they put those scopes in is right over the front of the tibial border, okay? And people will, particularly in weight-bearing activities when they're coming back, I don't care where it is, and we now know that you have to have some rotation, they will get a pain right here or right here, and they'll go back and get MRI'd, and they'll go back and get X-rayed, and they'll go back and get injected, and they can't get rid of it, and they think, what is going on? And actually, recently, we just had a total knee that had exactly the same complaint. You wouldn't think they would, and what it is where they put that scope in, they ding the coronary ligaments, and the coronary ligaments look like a C-clamp right on the top of that joint. So where they look at it, at the front of the joint with the C-clamp, and again, this took me a long time. It was when I was working with the orthopods that we sort of figured out what it was. They irritate that coronary ligament and it tightens down. And one of the things that has to happen with weight bearing is that your menisci need to ride up onto that tibial plateau a little bit and get out of the way of the rotary movement. If your coronary ligament's tight, you lose meniscal mobility, and they get that pinching sensation as soon as they have to weight bear and rotate a little bit, and it will drive them crazy. So there's a very easy test. And again, I say that when I retire, I'm gonna get disability for my thumbs because I've done so many, and you can see this one is bad, but I'm lax here. If you come on the top of the tibial plateau, so if I externally rotate them, what coronary ligament am I exposing? Medial. Come in onto the top of that plateau, horizontally push your thumb back into kind of that soft spot just off the ligamentum patellae. Come straight down, and right there is your coronary ligament. And you can come right along the plateau, and guess what these respond very well to? Frictions. And the deal is, you gotta do it, and they go, that is my pain. And it was one of my old partners that said, yeah, okay, I buy it now. And you friction them, and it doesn't take long, maybe, and you know, everybody goes, if you looked at, no, it wasn't Maitland, it wasn't Syriax, who am I thinking of? That was the big cross friction guy. It's the English, but anyway, they said, oh, you got a friction for 5 minutes. You ever try friction it for 5 minutes? I mean, and I watched it, now their frictions are like this, I gotta get this right. Anyway, push and then back. And then this is what their frictions look like, the English. Here's the Americans and Canadians. We're the drillers, right?
Drillers.
Okay, we're the drillers. And I had somebody say, oh, you Canadian, you're the drillers. And with the push and back. That's up to you. I suppose it's how you're taught. When you get onto these ligaments, anybody who's worked with me, you can actually feel like they're crunchy. Crunch, 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 crunch. Yes, Phil?
There's some research out, a gal did some research, I can't remember the name, that talks about doing the cross friction, one direction.
Yes.
So you're either pulling it or you're pushing it.
Yeah. And so, yeah, and I'm okay with
And
that.
she had what?
Better success than
The drilling.
the drillers.
Okay, so, I'm a driller. All right, so that's why I said, you watch the English do it, is push, relax, push. And I mean, I could probably do that for 5 minutes. All right, and they say it's the whole body doing that. Let's get it going, and you'll follow it right along the plateau. And so obviously the lateral coronary is here, and you're coming straight along the plateau as well. And it's very easy to pick up, and actually it's diagnostic, because as soon as that coronary ligament starts to move very, very quickly, the weight-bearing status goes right up. Yes, I'll do a little ultrasound with it after, okay? You can do some laser. Phil told me that laser works real well around here. What else?
The other thing is, sometimes I have people that are so sensitive, I can't put them in internal or external rotation. And those are the total joint stuff, where you can't turn it, so you cross friction, then you take up the slack.
Yeah, cross friction, sure. Take them into range, take up the slack. But it actually works really well in total knees. And the reason is, I think total knees are based on sort of what our knees really look like, and they're getting better and better. So there is that rotary component. So you do have to do that. And again, but scopes, they get the scopes right at the front. So if you get total knees after. And here's the other thing, somebody who's doing is picking up a lot of that coronal motion with their knee. Sometimes they'll irritate these ligaments, and that is the pain they complain of. Okay?
Started doing these dynamically also, so with the leg over the end of the table.
Oh, yeah. And I mean, you bet, you can do them over the end of the table, and we'll show you that in a minute. Yeah. So coronaries have a lot more to do with things. I think for a long time, we treated the patella when people have pain, and they go, yeah, that's not really where my pain is. It's sort of right here. As soon as I hear that, I'm thinking coronary ligaments.
And differentiate that between like infrapatellar fat pad irritation.
Infrapatellar fat pad irritation is a bitch when they get going, because based on that weight bearing status, and you'll find that fat pad, if you come onto the infrapatellar tendon, if you move it out of the way a little bit and hook underneath it, you're off the joint line, and that's where that fat pad will be. Superficial or deep. Superficials are the tough ones as well, because you have how many fat pads you have around the knee? Lots, all right? You have prepatellar, right? Pre-ligamentum patellar, subligamentum patella, so there's lots of fat pads around there, but those are the tough ones to figure out. But I just don't see a lot of that. Doesn't mean they're not there.
Do you think though with the scopes though, there's some scarring from the portal
Oh, yeah.
tube that's adhesing down? So it's not just that the fact that it may have kind of scraped or dinged the coronary ligament, but there's actual adhesions
Yeah.
built to it from
And
that.
And that's why we started doing them dynamically too, is because you
Different ranges.
They're
Can we just see
Right.
it right now?
Sure.
Yeah.
Yeah, just scoot to the end of the table for me real quick. Hang on. This table's probably a little low. Okay, good.
Use the other
This
table.
is fine, as long as this heel's not touching the floor. So basically with this, if I'm doing the medial coronary, I'm just gonna get, relax. Just gonna get right on the joint line, and then I can add in the conjunct rotation as I go from one position to the other. Just like that, and I can just work my way around. And that's the one that I tend to use more often with the post-surgical, because then I'm thinking, okay, maybe that coronary ligament's just not giving them that meniscal mobility as much as they need, and I'll do it there. And not that I won't do it in the supine position first to desensitize it a little bit, but I feel like we get a little bit better change in the actual patellar or the meniscal mobility when we do that there too.
The other thing is, if you take this one step further, have a stand up. The other way we've done it, I mean, at one time when I was seeing lots of hockey, bend your knee for us, okay? Pretend you're skating, right? Take him into this position, find it, and that, where he would get that moment with the motion, right? I take him right into that position, take it there, and actually friction him in that position. So, I mean, you know, that's good. That's just good thinking that you do that. So have a seat while we got you here. So the other one, yeah.
So